Okay. So as Daniel said, I'm working on implementing individual differences in patient population, and I'd like to invite you, if you have any questions or if there's something unclear, just raise your arm and I try to answer. So I was fascinated by research on mental disorders like very early in my, actually already when I was a student, because when you look at the history of psychiatry, it's characterized by in the 17th century, for instance, various treatment conditions that changed over the decades, and then in the 19th, 20th century, we started to look at biological factors that were involved in mental disorder research. In particular, work on the brain started then first time, and over the decades, we developed a classification scheme, the DSM-5, which we currently use. And it's basically a system based on symptoms, or symptoms characterization or symptoms classification, in which we look at a patient that comes to the clinic, and then we assess them on the basis of a specific set of symptoms, and based on the symptoms, they belong to a specific category, such as, for instance, schizophrenia or bipolar disorder or ADHD. And nowadays, we're interested in identifying biomarkers for all kinds of disorders, diseases, and mental disorders is certainly one of them. But there are no biomarkers for any of the disorders, except with one exception, that the BMI is important for when you have a eating disorder. But other than that, there are no biological markers. So one of the reasons one of the ways by which we try to identify biological markers is a standard case control analysis framework, where we have a set of regressors. In this case, let's say ADHD versus controls, or schizophrenia versus controls, and we look at brain activation. And that's, we have an MRI scan, and we look at the group differences. In the case of pattern classification, we try to do that the other way around. So we have a set of images and a diagnosis, or a diagnosis of patients associated with those images, and then we use these images to predict the diagnosis of those patients using some classification algorithm. And you do that in a specific way. So we train a classifier on, for instance, the whole brain. So we take each voxel as a feature in a classification algorithm and then make predictions for patients. We use searchlight approaches, where we have a certain sphere that we move across the brain and make predictions in each of those spheres, or we do some sort of feature selection prior to our predictions. And then we use cross-validation or out-of-sample predictions to validate the accuracy of our classification algorithm. So for instance, you split the sample into a part of training and a part of testing set. You train your algorithm in the training set and you test it on the testing set. You do that in a cross-validated way, for instance. And then we assess the accuracy, and there are various measures for accuracy. For instance, accuracy is one of them, balance accuracy, whatnot. So there's a whole literature on what kind of measures you should use. In the beginning, or early on, we have looked at the literature to identify all studies that have used pattern classification based on brain imaging data to predict mental disorders. So what we did, we developed a scheme where we divided those studies based on what modalities they used, how they extracted the features, what kind of classifiers, and then the kind of validation scheme they used. And we reported the accuracy as an outcome measure of their prediction, which is one value that gives you an indication of how well you can predict a mental disorder. And then, we looked at those studies. There were a number of studies that we identified, and we made a selection based on these criteria, and we ended up with this number of studies. And we tried to find a pattern in the literature and determine how well can we actually predict those disorders. It's quite surprising. I remember when I was at SFN, like in 2014 or 15, and people described the connectome of a worm, and they knew every single neuron in that worm and every molecule and what it did. And then I looked at my data and I thought, oh, that's quite removed from the worm predictome. And apparently it was very difficult to predict like the behavior of the worm, even though you knew the whole connectome and each single neuron. So I thought, okay, that's actually very surprising. Yeah. But then I looked in the literature, and here I found a specific pattern that were apparent across studies. So we saw that independent of modality and independent of diagnosis, there were an overrepresentation of small studies, and the accuracy was, to put it mildly, quite variable. So everything from 60% accuracy for the prediction of any of the mental disorders to 100% prediction was possible. These studies would probably suggest that we just should use neuroimaging to predict mental disorders, and those studies would probably suggest, oh, it's probably not possible. So where is the truth? It was very unclear at that stage. And then when I plotted these studies as a function of the sample size, then we saw that the accuracy dropped. And if you know anything about machine learning, that's very surprising, because you would expect the opposite pattern. With more examples, your prediction would improve. So then I tested that in a couple of samples and increased the size. We tested that in a couple of samples and increased the size of the samples considerably, and the pattern was, consistent. So with increasing sample size, the accuracy seemed to drop, which points towards maybe a selection bias or some sort of other bias in the earlier studies. And that was then kind of, other people looked at it in the same way, across different other mental disorders, diseases, and they recovered the same kind of pattern. And then there are a couple of reviews coming out that show the same now. So this is kind of, so it's surprising. So there are multiple factors that contribute to it, of course. So for instance, the heterogeneity of mental disorders, I'll come back to that later. Second, then sampling bias, as I mentioned already. So that when you have a small sample, there's a chance that you just select a group of patients that is very distinct from healthy is relatively possible in conjunction with a publication bias, with a potential publication bias, where studies that show higher accuracies are more likely to be published. So, and these conjunctions may explain some of the patterns. Anyways, this was a bit of a dismal conclusion for that work, but then we thought about the heterogeneity of patients. So what are patients actually? So you cannot assume that a patient group is uniform. It's consisting of many individuals, quite different biologically. However, in all these studies and in all the studies previously conducted, what people usually do is they look at distinct groups. So they assume that there is coherence in these two groups, and they subtract in one way or the other this group from that group. Even if you would use a multivariate classifier or a deep learning algorithm, as soon as you assume the validity of the labels, you make that distinction. And in this way, we argue that we introduce the average patient, because once you have a predictive pattern, you say this is prototypical for, let's say, schizophrenia. Well, maybe on average prototypically, but not really for each individual patient. So therefore thereby you introduce three kinds of, we termed that three kinds of heterogeneity into the classification scheme. First, you can get the same diagnosis of a mental disorder due to various different symptom constitutions. So you can get a diagnosis with ADHD based on predominantly hyperactive or predominantly inattentive symptoms. And the same is true for all of the mental disorders. Second, each individual with the mental disorder might end up in their symptom category just because of different biological mechanisms that lead them to this. And third, there's some environmental heterogeneity. So individuals may live in different families, and they either provide a protective or an adverse environment to develop one of those disorders. So therefore, we started to map the heterogeneity of mental disorders, and there are many ways of doing that. One way is, for instance, to have a hypothesis. Say, for instance, in this specific group, I assume that girls and boys are different from one another because of such and such. And then you look at biological variables that justify your claim. We looked at that in ADHD, in autism, and we found some differences between sexes. Another way is of looking into clustering, so automatic clustering methods. Here we wrote a review, similar style as the one that I mentioned before, but now we compared pattern classification clustering methods, so unsupervised and supervised methods. And we observed the following pattern. So this is a similar graph where you have a sample size and then the number of clusters reported. So if heterogeneity is a factor, I mean, this is very anecdotal, but if heterogeneity is a factor, you would assume that when the group is larger, you sample more of the heterogeneity of a specific population, and thereby you also increase the likelihood of identifying smaller subgroups. And therefore you would, or what I would have anticipated, and that seemed to have been the case, that with increasing sample size, you detect more subtypes. Although I have to say, of course, clustering methods are very arbitrary and you make many choices that lead you to the number of clusters that you identify. But one of the factors may be how rel and how heterogeneous your population is and how well you sample it. And then recently in the group of André Marcon and Christian Beckmann, the normative modeling was developed. And what you do there is the following. Here you have a growth chart. You know, maybe if you have children, when you go to the doctor and your child has a function of his or her age, has a specific height, and then the doctor says, oh, that's a bit out of the ordinary. You have to be careful there. Maybe there's some sort of deficit or disease, and we should check that. We applied the same principle to the brain, where we looked at gray matter, but you can look at all kinds of brain measures as a function of, in terms of a growth charting approach. So for instance, you predict the function of age, brain size, and specific brain loci. We did that across the whole brain. And you can look at individuals that fall out of this range in a specific brain location, so that are extremely outlying, these individuals and this individual. And you can look at their, what makes them different in reference to the norm. And this way, we aim to map heterogeneity and to move away from case control comparisons. But we believe that we can use this scheme in multiple different ways. So I would like to now show you a few studies where we did this, and then replications. And that's basically the talk, and the first steps, and then talk about what we do next. So if you have any question about it, let me know. So what we generally did, so that's true for all the studies that I'll show, we had a large group of healthies. Ideally, you have a healthy population cohort here. We don't have that for all of the studies, but that will be, of course, a goal. And then we built a Gaussian process regression model for age and gender and predicted different brain regions in terms of, in this case, VBM, free surface measures, thickness, area, and so forth. And then once you have built the model, you apply it to the patient cohort. And you look at how the patients behave differently from the controls, or we looked at how the patients behave differently from the controls. Most of those studies we use in the healthies, we usually use cross-validation, and we, in some cases, left out a separate healthy control group to test the models, just to be sure that cross-validation doesn't introduce a bias as opposed to out-of-sample prediction, which was, for instance, indicated by cross-validation failure by Gale a couple of years ago. And then we applied that to patients. And we looked at what's the proportion of individuals that extremely deviate from the normative range in both of these groups. And we built individual maps of deviation. We plot them, we look at the overlap maps, and we compare them across groups. So this is then how the forward model looks in one of those studies from Mariam. So what we have here is you see like the forward model of the normative model for age from age 6 to 30. And you see where the percentage of gray matter decrease in which of in the brain regions. You can plot the normative curve across age for specific regions. So you have to think that in each of these voxels, you basically have a growth chart. You cannot visualize them. You cannot visualize all of them, but this is what this figure represents. And this is just a selection of regions that we picked. And then we looked first at extreme outlying individuals, extreme negatively outlying individuals in bipolar disorder. And so that what you now see here is you see an individual patient. Instead of looking at groups or group differences, you see in which region this patient one deviates from the norm extremely. And you observe a pattern, and already here strikingly, I mean, these patients are sorted on the percent or on the number of deviations, of extreme negative deviations that they show in the brain. So you see that even the most extremely deviating subjects or patients have a quite unique pattern of brain differences. Of course, there can be all kinds of factors that lead to that deviation. So there can be, I mean, you know all about scanner artifacts and whatnot. So that can also contribute to that deviation, of course. So you have to be aware of this limitation. But you can devise methods and ways of dealing with it. So what we then did, we looked at all of them, so all of the bipolar patients, and we created an overlap map, which means that the regions that you see here, more than 2%, or the regions in red, more than 2% of the bipolar patients have an extreme deviation, an extreme positive deviation in those regions. And this is the extreme negative equivalent. So more than 2% of the patients have an extreme negative deviation in this brain region. This is, first of all, you think, huh, that's very strange. So there are only a few locations where there's overlap. And if you assume that if you have, what basically a diagnostic is a selection process. First, you have a population from which you select a subgroup of individuals based on specific behavioral properties. And this should, if that selection is biologically relevant and in line with and biologically relevant, and the measurement that you're taking can measure that biologically relevant property, then there should be more overlap as a function of a selection process, if that selection process tells you anything about biology. So that was surprising that for bipolar, we find little overlap. Did the same for schizophrenia. And then, oh yeah, here we look at the group comparison. So like a standard Palm kind of group contrast analysis on the Z statistical maps. And you see like a difference in the mean between the bipolar and healthy group. Then we looked at schizophrenia. We did the same for schizophrenia. And here you see, like, for instance, in patient one, that would be a typical pattern that you would, that's like textbook, like schizophrenia talk. Oh yeah, you have prefrontal differences in schizophrenia, and you have like a, maybe even in the history of psychiatry, schizophrenia was firstly associated with dementia precox. So it's a form of dementia and neural degeneration. So that patient would probably be put in that textbook as an example. And then, but when you look at all the other patients, they have a quite distinct pattern from that again. We looked at the overlap maps again, and the overlap maps recover the pattern, so but only at 2%. So 2% of the population, 2% of the patients extremely deviate in regions that you would have expected based on textbooks, extreme negatively. You see a pattern of positive deviation, and you recover like the normal mean pattern that we observe in most of those studies. So when we did the same in healthies, we expected this to see that pattern, so no difference in the mean. Then some overlap in the positive, extreme positive deviations, and no negative deviations, because there's little to no neurodegeneration. If you compare all these three groups to one another now, you can observe a couple of things. So first, okay, you observe the pattern as you would expect in the mean between those three groups. Second, this is not significantly different, so there were no extremely more positive deviations, schizophrenia, bipolar, and healthy. A bit surprising, because some of the medications in schizophrenia, for instance, they lead to an increase of brain volume. So I would have expected that. And a little bit is seen, but not too much. But in the extreme negative pattern also is what you would expect. So we find a significant difference between schizophrenia patients, bipolar patients, and healthies and schizophrenia patients. Okay, but this group distinction we just made not to make a group comparison, but to be able to make determine that at least some of our differences or some of the extreme deviations that we found are actually associated with diagnosis and not with movement or whatever in the scanner. Then we replicated that in ADHD, which yielded the same kind of pattern. And this is one sample with healthies and adult ADHD patients. We observe an extreme negative deviations more than in the healthies. You find group differences, but the individual differences are extreme, so you have little overlap. Then I replicated that now recently, or we replicated that recently in another ADHD sample with healthies. Same story, pattern in healthies, but there are two scanners in this sample. It's very important to be aware. Even manual scanner differences are usually the easiest to be predicted in whatever study you do. So they are like, it's absolutely necessary to find better ways to deal with it. Currently trying to think about it, but it's very hard because as soon as you have multiple scanners, disentangling scanner effects from the disease effect is very hard in this framework. But it's true for all studies, basically, or also for the classical studies. And then we had a bunch of siblings from patients. So I think this pattern is more extreme because we have two scanners, and there is some sort of imbalance in the sample a little bit. But I'm currently trying to deal with it. But the general pattern is recovered. So we have 2% again. The overlap is a little bit more in this sample in children with ADHD than in adults with ADHD. This may be due in parts to the scanner effects, but I've tried to deal with it as good as I could. And then you have unaffected siblings, which don't show the symptoms. So they don't show the symptoms, but they have a genetic, higher genetic load for ADHD in this case. So you would expect them to be in between those two groups. And it's something that we recover, but still the individual differences are extreme. And then that brings me to the last replication study, where we looked at, in this case, Alzheimer's disease, mild cognitive impairment, and schizophrenia. So Alzheimer's disease can clearly be identified with structural MR. So you would expect that the effects in this group are the strongest, then in mild cognitive impairment, and then in schizophrenia. We had a very large healthy cohort, and this allows us to identify the normative models more reliably. And the overlap in the healthy group is even less. So there were only a few locations in the brain that deviated, that overlap with in 1.5% of the healthies. So when you looked at Alzheimer's, you saw like a lot of overlap. So it's not surprising. So they extremely negatively deviate from the normative model. But in particular, what is reassuring, we recover a pattern in the, I cannot see it here. Here, the hippocampus. You can see that better than me. Here, I think, yeah. And they're like up to 80% of all the individuals have extreme negative deviations in the hippocampus. That's reassuring. So the general principle holds, and it's what you would expect. Then mild cognitive impairment, which is a form of pre-dementia. You have like reduced cognitive scores on cognitive tests early in your life, but you haven't like the full set of symptoms associated with any of the dementias yet. But it's a risk for dementia. And we see a degenerative pattern in 25% of the individuals with the diagnosis. And for schizophrenia, in this sample, we did the same. And here the overlap even decreased compared to our earlier sample. So it's at 4%. I think it's because we have a better normative model. It's also scanned on one scanner. So we can replicate the earlier findings. So that brings me to the conclusion. So conclusion one is, early research in small samples exaggerate the predictability of mental disorders sometimes. This points to large heterogeneity and problems in earlier studies. We have talked about that. And second, instead of chasing the average patient, we would suggest to map heterogeneity, the level of the individual. And fourth, there still needs to be a lot to be done. I hope I have convinced you now that we can map heterogeneity in this way across different disease groups. Second, that we can move beyond case control comparison. And then this is what remains, or this is some of the things that remain to be done. So we need to integrate different modalities, build a normative space for subsequent stratification. So you can bring everything into the same space using that framework and then stratify. And then in this way, eventually move towards more precision medicine for complex diseases and disorders. I'd like to thank particularly Andre Macon, Christian Beckmann, and Lars, but everyone here who contributed. And Andre was my supervisor doing my PhD. And I'd like to point you to a conference that we're currently organizing in Lima, Peru. If you are interested, feel welcome. We have, I think, some awesome speakers, and it's going to be a lot of fun. So, yeah, I think I'm a bit fast, actually, but I hope you have a longer lunch then. Yeah, thank you.